two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 93. And today I'm joined by my co-host, Dr. Jose Checo. So welcome, Dr. Checo.
Hi, Swapnil. How are things down in Sydney?
Things in Sydney are pretty good now. I think we're back on track, and obviously we're getting a lot of non-COVID patients, and ICUs are getting more busy now. Yeah, and I think there is new variant, but very less virulent compared to Omicron and Delta. So overall, things are heading in the right direction. How about India?
That's good news. In fact, our ICU in Bangalore is closed down now, the COVID ICU, because there are no patients at this point of time. And hopefully it stays that way in the days to come.
Yeah, no, I think that's probably the global picture, I guess. So today we are going to do Journal Club, and we have found a population-based study, which is more of an observational study. And usually we don't discuss observational study. We prefer to discuss randomized controlled trials. But this study is interesting purely because the question that it has raised is really poorly answered so far. And although a lot of practices are variable we really don't know the answer around this question. And the question is really which agent or which drug is the ideal choice of drug in patients with post-return of spontaneous circulation after out-of-hospital cardiac arrest. Now, when you look at the guidelines, obviously the hemodynamic optimization is crucial after achieving the ROSC in out-of-hospital cardiac patients. The guidelines usually point out that there is no head-to-head comparison between vasopressors which are available. And so what are the choices which we got are either noradrenaline, adrenaline, or some of the inotropic agents such as isopropanol, or some of the other vasopressors such as metreminol. Now, there is no standard answer to this question that which agent is better than others in patients with out-of-hospital cardiac arrest. Traditionally, during the cardiac arrest, we use adrenaline boluses as a part of the algorithm. But once they achieve the ROSC, usually we prefer to use noradrenaline infusion, at least here in Australia and New Zealand. But really, the evidence behind it is very poor. In fact, it's more of an anecdotal evidence that we kind of extrapolated from our experience of use of noradrenaline in patients with septic shock. And again, there is overall growing evidence of usefulness of noradrenaline in patients with sepsis shock or cardiogenic shock. And usually that remains usually the first choice of agent because adrenaline has got its own side effects such as tachyarrhythmias, increase and lactatemia. So I guess this study is timely and interesting to discuss which agent is better and whether that choice of agent can affect overall mortality. So Dr. Checo, can you please walk us through the study methodology and the results of this trial, please?
Yeah, so this study was published in Intensive Care Medicine earlier this month, and it is titled Epinephrine versus Norepinephrine in Cardiac Arrest Patients with Post-Resuscitation Shock. So this is a registry-based observational study. The authors identified patients admitted alive after out-of-hospital cardiac arrest to 5 university hospitals in France over a 7-year period between May of 2011 and May of 2018. Patients were in post-resuscitation shock, which was defined as a need for vasopressors for more than 6 hours in spite of adequate fluid resuscitation, while targeting a mean outflow pressure of more than 65 millimeters of mercury. They excluded patients with a non-cardiac cause of cardiac arrest, including things like trauma, drug overdose, drowning, and so on. Refractory cardiac arrest with no sustained ROSC was also an exclusion. Refractory shock requiring ECMO were excluded. No requirement for intravenous epinephrine or norepinephrine was an exclusion, and patients who were already on both the drugs running were also excluded from this database study. So they identified 1,421 patients who were in post-resuscitation shock. And after exclusions, 766 patients were included in this retrospective observational database study. And among these 1,421 patients, 481, 63%, which is the majority of patients, were treated with norepinephrine infusion, as is the general practice around the world, while 285 patients, 37%, were treated with an epinephrine infusion. And if you look at the study population, 73% of patients were male, as you would normally see in a study like this. And the median time from the time of collapse to CPR was 5 minutes. And from CPR to ROSC was 22 minutes. So these are median times. During the first 48 hours of ICU, the maximal epinephrine dose was 0.7 micrograms per kilogram per minute. That's a median dose. And in the norepinephrine group, the maximum dose was pretty similar at 0.6 micrograms per kilogram per minute. The median duration of vasopressor support with epinephrine was 24 hours, and that with norepinephrine was 30 hours, all pretty much similar, statistically significant difference in these variables. Overall, 31% of patients survived to hospital discharge, which is in fact maybe slightly higher than what you would normally see in a cohort of out-of-hospital cardiac arrest patients. 31% survival to hospital discharge. What were the outcomes that they looked at? The primary outcome was all-cause hospital mortality, and they found that the all-cause hospital mortality was significantly higher with epinephrine use, 83%, versus 61% in the norepinephrine group, p-value of 0.001. Secondary outcomes included cardiovascular specific mortality, again, higher with epinephrine, 44 versus 11%. The cardiovascular specific mortality could be either due to recurrent cardiac arrest or mortality from refractory hemodynamic shock. This was actually the definition of cardiovascular specific mortality. So both these, recurrent cardiac arrest and mortality from refractory hemodynamic shock leading to mortality, was significantly higher with epinephrine compared to norepinephrine, again favoring the use of epinephrine. They also looked at the neurological status, which was assessed using the cerebral performance category score. A score of 1 is good recovery, score of 2 is moderate disability, 3 is severe disability, 4 is a vegetative state, and 5 is death. So they classified 1 or 2 of neurological status as favorable by the cerebral performance category score, and anything that ranged from 3 to 5 was considered to be a poor neurological outcome. And they found that a favorable neurological status was significantly higher with norepinephrine compared to epinephrine, 37% versus 15%. Now, because it was an observational cohort from a database, there could be several confounders and biases. So to compensate for these, they performed 2 special analytic techniques. First was a multivariate logistic regression analysis, including the common factors that lead or that decide outcomes after cardiac arrest, including age, gender, bystander CPR, initial shockable rhythm, time from collapse to CPR, time from CPR to ROSC, epinephrine dose during resuscitation, arterial pH, evidence of myocardial dysfunction, targeted temperature management, and percutaneous coronary intervention. So these were the variables included in the multivariate logistic regression analysis. Even after including all these possible variables, epinephrine infusion was independently associated with all-cause hospital mortality, odds ratio being 2.6, 95% confidence interval, 1.4 to 4.7, p of 0.002. Epinephrine infusion was also associated with an increased risk of cardiovascular mortality on adjusted odds ratio and with an unfavorable neurological outcomes. So epinephrine seemed to have performed poorly with all these outcomes. They also performed a propensity score matched analysis on 93 pairs of patients. This again is to make sure you have a level playing ground in a retrospective observational study like this. So on analysis of 93 pairs matched based on a propensity score, continuous intravenous epinephrine infusion was associated, although non-significantly, with all-cause mortality, odds ratio 1.8, confidence level 0.94 to 3.4, which was just short of being statistically significant. They also performed a sensitivity analysis after exclusion of moribund patients, after restriction to patients with a cardiac arrest hospital prognosis score, which is a CAHP score of less than 150, restricted to patients with a CAHP score of more than 150. CAHP score higher means worse outcome. And they also performed a sensitivity analysis after exclusion of patients treated with epinephrine before ROSC. But even after this sensitivity analysis, the results were similar, favoring the use of norepinephrine infusion. So essentially, this study showed that in patients presenting with post-resuscitation shock following out-of-hospital cardiac arrest, epinephrine infusion compared to norepinephrine was associated with a higher all-cause and cardiovascular specific mortality. And the authors suggested that clinicians may consider that norepinephrine may be preferred over epinephrine until you do a proper randomized clinical trial.
Thanks, Dr. Checker. So I guess the whole topic and the question that this trial has asked is quite interesting, because really what we are looking at is a post-return of spontaneous circulation cardiogenic shock, because there are two potential attributes to this hypoperfused state when patient achieve the ROSC. One is obviously the myocardial stunning, which leads to features which are very similar to cardiogenic shock. But also the second component is due to vasoplasia due to ischemia reperfusion injury, which occurs in the post-ROSC phase. And that leads to more of a vasoplegic shock, needing more of a vasopressor response rather than more of an inotropic response. So usually the combination of cardiogenic shock and vasoplegia is usually the underlying problem in post-ROSC state. And that's why which agent is probably better is always debatable. Now, on the physiological side of things or the pharmacological side of things, epinephrine sounds to be the better option because it acts on both alpha-1, alpha-2, beta-1, beta-2, and beta-3 receptors. And it can contribute both vasopressor action and also provides inotropic action. While on the contrary, NORAD is predominantly vasopressor action, and it can have inotropic action through improving the coronary perfusion. Having said that, adrenaline can have potential side effects such as increased arrhythmogenicity, and that might actually worsen the cardiogenic shock. So I guess the evidence before this trial was quite poor. There is one pilot RCT in the setting of cardiogenic shock, which did not find a difference in survival between patients who were given adrenaline versus noradrenaline. Having said that, this trial included only 30 patients. And there's another recent randomized controlled trial, which included 57 patients with cardiogenic shock secondary to myocardial infarction. Again, did not show any mortality difference with the use of adrenaline or noradrenaline. And there are two recent RCTs called as Neuroprotect and Coma Care RCTs, which assess the goal-directed hemodynamic management with low normal versus high normal map targets in patients with out-of-hospital cardiac arrest. And again, found no difference in the primary outcome. So overall evidence which was available till date on this topic was quite poor. And I think that's what was reflected in the guidelines, that either you can use adrenaline or noradrenaline in patients with ROSC after cardiac arrest. Now, this is probably the first study which demonstrated that use of continuous IV adrenaline infusion in this subgroup of patients is harmful. Having said that, we have to take this with a pinch of salt because there are a lot of limitations of this trial. I guess the first and foremost limitation I can see is obviously this is an observational study. This is not a randomized controlled trial. And both groups were not matched at the baseline. In fact, there are several risk factors of poorer outcome were more common, such as unshockable rhythm, longer time from CPR to ROSC, lower blood pH at the admission, and myocardial dysfunction. So I guess given that obviously the epinephrine group was supposed to do poorer given the baseline inequality. Having said that, authors argue that they obviously did a lot of different types of analysis, propensity score matching. So that shouldn't be a problem. But obviously, even the number of patients included in both groups were not the same. And I guess patients who were enrolled in this trial did receive adrenaline during the cardiac arrest. And I guess that might have already worsened the outcome. We don't know. And because this is not a randomized controlled trial, it's hard, but it has definitely asked a question. And I don't think we still have answer to it. But from the anecdotal practices or from the anecdotal evidence point of view, I think we know probably that NORAD is probably the better agent than adrenaline. What's your thoughts, Dr. Checker?
Yes, I agree, Swapnil. The study has all the limitations of a database-based study. Purely observational outcomes are evaluated. So you really cannot come to any kind of definitive conclusions based on this study alone, although it's a pointer to the fact that the use of adrenaline infusion post-cardiac arrest may carry with it poor clinical outcomes compared to the use of noradrenaline. In fact, I think the general practice is to use norepinephrine anyway in most parts of the world. That's what we've been using as well. Perhaps there are exceptional situations in which you would use epinephrine compared to norepinephrine, but this is few and far between. As you mentioned, the epinephrine and the norepinephrine groups were not really matched at baseline, as you would expect in an observational study, although they performed multivariable logistical regression analysis and propensity score matching. It still doesn't really add up to the effect of doing a randomized controlled trial. So we can only take this as a signal that perhaps the use of epinephrine infusion post-cardiac arrest after return of spontaneous circulation may indeed be harmful, may be associated with poor clinical outcomes, including mortality, as well as neurological outcomes. And perhaps there is good reason to continue with the current practice of noradrenaline infusion as default in this scenario. The other question is, which I have been interested in as well, is regarding the use of adrenaline in cardiac arrest, the bolus dose of adrenaline that we use as part of the resistive interventions in cardiac arrest. Not much of evidence there as well. Again, there are some observational studies which suggest that adrenaline may not really do very much in terms of hardcore clinical outcomes. But that again remains to be explored. We follow a tradition-born approach of using adrenaline, and we of course see many patients return to spontaneous circulation with its use, and we continue the practice without asking questions. But perhaps there is a need to evaluate the use of other drugs as well in this scenario, and maybe a trial is called for in that direction as well.
Yeah, I agree with you. And I guess the issue with conducting a randomized controlled trial in this kind of topic is very hard and it's quite challenging, especially because the number of patients required to achieve the difference in primary outcome is quite large. And also, we don't get that many patients with out-of-hospital cardiac arrest that routinely in ICU to enroll into the trials. And also, I guess, choosing which patients should go in epinephrine group versus norepinephrine group is still quite debatable. And I guess, as we mentioned, probably we have moved away from using epinephrine or adrenaline regularly in our patients with out-of-hospital cardiac arrest. The proportion of patients that we use adrenaline is quite less. Usually the indication for use of adrenaline in post out-of-hospital cardiac arrest phase is usually for sustained bradycardia and as a more of a chronotropic agent rather than as an inotropic agent. And sometimes we do use kind of combination of adrenaline and noradrenaline to achieve inotropy and vasopressor action. But isolated use of adrenaline overall is quite rare in my practice. So I guess you're right. So this study probably won't change the current practices, but at least it will validate that what we are doing at the moment is probably in line with some of the evidence that is available from the registry data.
Yeah, that is very true. I remember when I used to work in a post-operative cardiac surgical unit a long time ago, we used a fairly heavy dose of adrenaline in patients who suffer cardiac arrest and follow it up with an infusion as well. Of course, that situation cannot be compared to the out-of-hospital cardiac arrest scenario that we see in this study. And among those patients who suffer cardiac arrest in the post-operative cardiac surgical scenario, the two most common causes of arrest is pericardial tamponade, one, and second would be graft failure, both of which would require opening the chest anyway on an emergency basis and drain diffusion or regraft. So that's a different kind of scenario because obviously the LV function is poor in that situation, and perhaps adrenaline would be a better choice in that scenario. But it was pretty much tradition-born use, but I still remember we used a pretty heavy dose of adrenaline and an infusion of adrenaline in many of these patients.
Actually, I was struggling to even remember last time when I used the adrenaline infusion in patient with out-of-hospital cardiac arrest in last 10 years. So yeah, so I overall, it's interesting study and which has asked a very interesting question. And I think, as you said, probably a larger randomized controlled trial will probably address this question once and all. But till then, I guess what we are doing probably the right way to manage the patients with out-of-hospital cardiac arrest with ongoing infusion of noradrenaline compared to use of adrenaline infusion. So thanks, Dr. Checker. Thanks for your time. That's the end of our today's podcast. We'll be back with another controversy in critical care in weeks' time. Till then, goodbye and have a nice time.
Thanks a lot, Swapnil. Thanks everyone for listening in, and we'll meet again for our next episode.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.